Hi and hello everyone. Today I would like to share about a case study which I was done after my clinical practice at emergency trauma department at Hospital Sultan Amina. My case study title is the clinical evaluation, finding and management of a patient with acute myocardial infarction. In introduction, I would like to mention that I was attending clinical session for 10 days at emergency department in Hospital Sultan Amina, Johor Bahru. Emergency department is a department which consists of red zone, resuscitation zone, SARI zone, yellow medical and trauma zones, green zones, observation room, downflow COVID and outflow COVID, asthma zones. These all zones will be providing emergency care and treatment to the patient. Emergency department is also responsible for delivering immediate and medical and surgical care to patients who presented with life-threatening and non-life-threatening emergency problems. I have been choosing acute myocardial infarction as my case study because it is a common life-threatening cases that I often was meted and treated in a hospital, Sultan Amina. Is the anatomy of the heart is a general view of anatomy of heart. There is a superior vena cava which bring the deoxygenated blood to the right atrium and left atrium ventricle. There is the aorta is the biggest artery which bring the oxygenated blood to the left atrium and left ventricle be pumped to the whole body. Okay, we come to the my case study. My patient's demographic data. My patient is named Krishnasamy Analaki Rao. He is a 53 Indian gentleman. The date of admission of the patient is 24th March 2022. Patient is arrival at ED red zone by a triager. Patient was occupational as a lorry driver and patient is a Malaysian. Patient's chief complaint is a left-sided chest pain for 1 day. He having a medical illness of diabetic mellitus and hypertension over 5 years. Patient was having a left-sided chest pain while driving the lorry. Patient complained that it's like a camping-like pain, and the pain was radiated to the left upper arm. And patient also claimed that having a one episode of vomiting. On the examination, patient is alert, conscious, pink, good pulse volume, warm peripheries, CRT below 2 seconds. When patient is also GCS full, patient is a walk-in to the zone. Patient blood pressure is 206 systolic and diastolic will be 120. Patient BP is very high. Patient having a heart rate of 75. Patient oxygenation is normal 99 under room air. Patient temperature is normal. Patient respiratory rate is also normal. Patient's pain score is 6/10 upon arrival. Patient having a lungs is a clear and air entry is also equal on auscultation. Patient CVS is a dual rhythm and no murmur and pelvic and abdominal examination is soft and non-tender. Okay, we come to the management of the flow which I was helped in the zone. Patient is initially assessed and primary assessment done by a triager and patient was bring to the red zone immediately. Patient was registered and open a new clocking sheet by a staff nurse. Patient position in the lying state on the bed and patient immediately attached a cardiac monitor. Vital sign was taken. Patient was initial ECG is done. Patient after done the left side ECG, doctor was ordered to do the right sided ECG as well and also a posterior ECG. And then the blood specimen was taken like a patient renal profile, full blood count, coagulation profile. Infusion glyceryltrinate GTN 7.5 mg per hour to bring down the BP because patient having a diastolic and systolic is high BP. And then patient was medication served is a tap crush aspirin 300 and tap clopidogrel 300, and also a sublingual GTN was given as as a ACS, an anticoagulant vector. Patient was started IV IV, given a IT stat dose of IV morphine 2 mg, and patient was given a metoclopramide 10 mg as well because patient was having a side effect of vomiting. And after the BP was stabilized, patient was started a IV 1.5 mega unit streptokinase over 1 hour. After this 1 hour, patient was started a normal night drip maintenance 4.0 for 24 hours. In the process of 1 hour of the duration of start IV streptokinase, patient was is patient was in pain. Patient was closely monitored, and then patient was treated. Infusion IV glyceride phytate GTN 0.5 mg per hour was started to bring down the BP because patient having a diastolic and systolic high BP. And then patient was served with medication tap aspirin 300 mg and tap clopidogrel 300 mg stat dose, and also a sublingual GTN for pain relief. Patient was given IV morphine 2 mg for pain management, and also given a metoclopramide 10 mg because patient having a side effect of vomiting. After 10 minutes, patient BP was bring down. Patient was started IV streptokinase 1.5 mega unit over 1 hour. The 1 hour was a close monitor with the patient because patient will be deteriorate anytime, and patient having a complication of streptokinase. After the infusions finished, patient was started IV normal saline maintenance 4.0 24 hour and GMR hourly, and also patient was nil by mouth. And then the all document was documented nicely, and then patient was also stabilized, and then the relative care also was given. In investigation finding, patient ECG was found. Finding is a ST elevation in 2-3 AVF and a ST depression in AVL. No posterior involvement, but ST elevation in right-sided partially involved. In post-streptokinase ECG shows the resolved ST elevation in 2-3 AVF. In conclusion, patient was a successful thrombolytic by streptokinase. This is the post-strep ECG and pre-strep ECG. There is a comparison. Patient initial ECG was ST up over 2-3 AVF. Here, 2-3 AVF. And then the after post-strep ECG is a resolve of ST elevation. In radiology finding, this is a AP view of X-ray of patient. The patient ECG X-ray is noted consolidation, minimal consolidation over right lower zone, and cardiomegaly as well. In laboratory tests, the FBC is normal, RP and COAC also normal, but in CE, the creatinine kinase was elevated. That is the cardiac ischemic was happen. That is the proof of cardiac ischemic was happen. Therefore, in overall, these patients' diagnosis is acute inferior ST elevation myocardial infarction with right-sided involvement, and patient is a KLIP1. Myocardial infarction is a myocardial injury due to ischemia. This defined pathologically as myocardial cell death due to prolonged ischemia. This also could be defined as a lack of blood supply to the myocardium from the coronary artery causes necrosis of the heart muscle due to the thrombosis or erythema or embolus. STEMI is diagnosed when there is a specific criteria. First is a ST elevation of 1 mm in two contiguous leads, or a new onset LBBB in the resting ECG, that is a left bundle branch block, or patient in with ischemic type of chest pain more than 30 minutes, that is a typical chest pain, and accompanied by a rise and fall in cardiac biomarker. This is the evidence of very evident and the predisposed factors that will be considered in STEMI. What is the etiology of the acute myocardial infarction? First, the coronary artery diseases. That is the one of the biggest etiologies. Valvular heart diseases, which is congenital diseases. Hypertension, cardiomyopathies. The evaluation of atherosclerosis will be resulting acute myocardial infarction as well. There will be uncontrollable factors and uncontrollable factors. Sorry. Next, there will be uncontrollable factors and controllable factors which will be predisposed for the acute myocardial infarction. The uncontrollable factor which we can't change is genetics, culture or race, gender and age. And the controllable factors which include high cholesterol level, smoking, alcohol and drug abuse, diabetic mellitus, obesity, lack of activity or hypertension. These are the controllable factors which we could be overcome by few strategies. In acute myocardial infarction, there will be a four key leap. They'll be classified into four key leaps. First, no sign of pulmonary or heart failure. Second, class 2 is a moderate heart failure evident by bivalve cramp or SG gallop or apnea or evaluation of JVP. Class 3 will be severe heart failure. There will be pulmonary edema. And class 4 will be patient already in the shock with diastolic BP of 90 below and evidence of peripheral constriction, diaphoresis, peripheral cyanosis or mental confuse or oliguria. This is the pathophysiology of the myocardial infarction. That is a pathway of the myocardial infarction occur. The pathological effect, there will be a local ventricular, left ventricular remodeling and reducing contractility. There will be result of ischemic mitral regurgitation. There will be cause of three type of the phenomena. There is a left atrium dilation and increase in left atrial pressure. Left ventricular dilation, there will be increased left ventricular pressure, and also this will be result of overload of the volume, and this will be cause the stroke volume, that will be pulmonary hypertension, that will be uh, increase of wall tension, and oxygen consumption also will be increased. In resulting will be ischemic, and there will be heart failure or death. According to the sign and symptoms, there is the few typical sign and symptoms which associate with chest pain or ACS or acute myocardial infarction. Persistent chest pain for 20 minutes. The area will be mid-chest, not relief with GTN, sublingual GTN. Radiated pain to the arm or shoulder. Difficult breathing. Vomiting and diarrhea. Sweating or having a cold sweaty skin. Anxious, syncope, fast and weak pulse, pallor, hypotension, fever, pericardial rub, tachycardia, arrhythmia, congestive heart failure, bivalve cramp, or increased venous pressure. Those are the sign and symptom of myocardial infarction. The complication of acute myocardial infarction, there will be a few. The first is a heart failure symptoms, cardiac aneurysm, a reoccurrence or reinfarction, they be cause of arrhythmia, ventricular tachycardia or ventricular fibrillation. angina, thromboembolism, systemic emboli, hypotension or cardiogenic shock, rupture of the heart, myocardial mural, papillary muscle, intraventricular sputum, mitral insufficiency or regurgitation, pericardial effusion or pericarditis, mitral insufficiency or regurgitation, Dressler's syndrome. Those are the complications which leads to the death. Differential diagnosis. Those are the common misdiagnosis or differential diagnosis will be same symptom with the acute myocardial infarction, such as the pericarditis, pulmonary embolism, acute bronchitis, acute pulmonary infarct, acute aortic dissection, triple A, ruptured esophagus or esophagitis, perforated papillary ulcer, pancreatitis, pneumothorax, unstable angina, or gallstone colic. From this case study, there will be few learning outcomes should be established. In the field of assistant medical officer, we should be um, responsible for giving a health education to the patient as well as the family patient. Take the proper medication with directed by the doctors. Come for the proper follow-up according to the set time and date. Patient evidence on food control, which like fat, sugar, and salt consumption. Do not smoke or drink. Control weight, exercise regularly, and having a healthy lifestyle, as well as take care of the good hygiene. There will be few precautions which clinically doctors and MAs should be taken note. There will be 40 to 50% of patients with myocardial infarction have an initial ECG of at presentation is normal. Patient will be deteriorated, patient will be changed, patient will be whatever will be happen within 6 to 24 hours. So there will be a serious case and statistic will be proven. So if patient has a normal ECG but the history is suggestive or even compelling, it is a vital to observe the patient or an extended period to get additional ECG tracing and determine if the patient chest discomfort or other symptoms are reoccurred. Prognosis of this AMI, 50% before reaching the hospital will be cause of death. 10 to 20% in hospital in the first week of admission will be death, and 20% within 2 years are dead. Acute myocardial infarction is a severe case, a severe complication, and lead to the death. That's all. Thank you very much. This is my presentation, and I hope everyone is understand my sharing what I have learned from this clinical practice is appreciated. Thank you.